Hi, everybody. Welcome to tonight's Your Space presentation in our very rapidly arranged alternative format. We're really thrilled to have Dr. Bill Mahoney with us tonight to discuss treatment options for children with ADHD. We're going to skip past that because we're not even on those things. And okay, Bill, here we are over to yours. And there.
Okay. Hello, everybody, and thank you so much for your patience. We maintain our blood pressures when things like this occur. So thank you for coming and taking the time. And what I'm hoping to do tonight is to discuss the treatments of attention deficit hyperactivity disorder, discuss issues of medication, and a lot of what I'm going to be talking about is about medication, because this is an area that many parents have a lot of questions about. I'll have a brief discussion about some alternative treatments that you may have heard about, but above all, I want to answer your questions. Now, there is a chat function to put questions you might have in, and we'll make a decision on an ongoing basis whether to deal with it then or to wait until a little bit later. But please feel free to ask any question at all. Okay, can I have the next slide, please? Okay, so when we're talking about ADHD, and particularly when we're talking about medication, it's really important to know that ADHD is felt to be due to differences in the way the brain works, and particularly the brain processes responsible for paying attention, planning how to do things, screening out external stimuli, and the ability to sit still are not functioning the same way. Those areas of the brain are not functioning the same way in many children with ADHD. A lot of these processes, also some of them are called executive functions, are felt to be associated with the front part of the brain, the frontal lobe and the prefrontal cortex, which is in the front part of the brain. And this is the brain area responsible for those functions. We know that genetics or brain injury can be a significant contributor to why those areas of the brain are not functioning. But at the very small, tiny cell-to-cell level, it's felt to be due to problems with the amount of neurotransmitters that are available for certain functions. Can I have the next slide, please? So this is a picture of a brain, and if you look on your left as you're looking, that's the front part of the brain, and it's connections between the front part of the brain and the very bottom of the brain, and connections to that back and forth seem to be the area of difficulty that children with ADHD have. And in the middle part, right where the pointer is, that area is where a lot of the sort of circuits of transmission are. Okay, can I have the next slide, please? This is to illustrate the point. This is a picture of someone trying to control an impulse. Red means that part of the brain is working hard. Blue means that part of the brain is not working so hard. And there's balances there, but you can see that the top part and towards the front part of the brain are working really hard as almost trying not to do something. And it's the difficulty with those parts of the brain working hard that seem to be the basis to ADHD. Next slide, please. Another very important concept is the way brain cells talk to each other. So the big hairy thing on the top is where a signal goes into the brain cell. It goes down that yellowy part and then goes to the dendrites that are at the bottom. And then that insert picture is a little tiny picture of how one cell is talking to another. The little yellow dots are neurotransmitters, and they go from the pink brain cell to the blue brain cell. And if some's still wandering around there, it gets sucked back into the pink brain cell. And that's what's happening as brain cells are talking to each other. Okay, next slide, please. Now, there's certain different types of neurotransmitters that the brain uses, and some of them are very specific to these areas responsible for ADHD. So one is norepinephrine, and we know what norepinephrine does in the brain when it's active. Those circuits, it dampens noise, helps us to plan, and increases our ability to inhibit impulses. And you can see, as I said before, how the connections go from the front part of the brain down to the middle part of the brain. Can I have the next slide, please? The other chemical that's there is called dopamine. And what we know that dopamine does, you can see it has similar connections to the norepinephrine. It improves attention. So it improves the ability to focus, to look for funny things at what we're looking at, helps our knowledge acquisitions, help us stay on task with our behavior, and stay on task and concentrating on doing things. And so you can see how these neurotransmitters are different, but there's overlap between them, and one will stimulate other pathways. But these are the key neurotransmitters in ADHD, and also what the medications for ADHD, they target these systems. Okay, next one, please. So to illustrate another point is that on the left is a brain just working at rest where the person does not have ADHD. The brain on the right is the brain just working at rest of someone who does have ADHD. And you can see there's a lot more blue and on the brain on the right than there is on the one on the left, and not nearly as much red. So what that means is that the brain of someone who has ADHD, some parts of it are actually working much less in general at rest than people without ADHD. And that explains why we use stimulant medication as a treatment for ADHD, because it makes that blue part of the brain turn more yellow and red, basically. And that's sort of the contradictory thing about ADHD, because so many of the children seem to be active and busy and think their brains are all over the place. But in actual fact, the parts of the brain needed to concentrate and to sit still and pay attention are not working as well. Okay, the next slide, please. When we're thinking about treatment or management for ADHD, we have to acknowledge and know that children with ADHD exist in multiple environments, and they have multiple relationships within those environments. So they have relationships with their parents, their teachers, with peers, their siblings. They have their academic and behavioral functioning at school. There's family functioning at home, and there's also functioning at leisure activities. And children with ADHD can have variable function depending on their interest and their talents in all of these different areas. But if we're thinking about management, we have to consciously think, what are the targeted environments that we are hoping for the child to improve in when we're thinking about treatment? Because a treatment may be different, say, if a child's playing hockey when COVID goes away, versus sitting in class and doing math. So those are very, very different activities. And we have to target what we do at those occasions when the child is in those different activities. Okay, the next one, please. Okay, another thing that's important about ADHD as a treatment is that ADHD is often complicated by the child having other conditions as well. It's very common. And so we know that up to 50% of children who have ADHD often can have quite oppositional behavior or significant behavior problems like conduct problems, which are things like stealing and severe aggression. About a quarter of them to 30% of them also have anxiety, We know they're at risk for things like depression, and that can develop in up to 20% of children and adolescents with ADHD. And then other developmental disorders such as learning disabilities can also occur in children with ADHD. And part of the assessment and management, remembering, respecting, and dealing with the fact that these other problems can perhaps be the target of that's needed for intervention as opposed to just ADHD in general. Okay, next slide, please. So some of this you may know, but there's different modalities of treatment for children of ADHD. And one of the first is information and education for parents and teachers. And that's what a talk like this is part of. It's giving you information that you can use in how to help your child and making decisions on their behalf of the best way to help them. We know that environmental change can help children with ADHD. An example of that, that was common, there were a number of schools here in Hamilton that were open concept schools. Some of you may have attended them. They were very, very noisy. And children with ADHD had a devil of a time trying to function in them. But then if you put them in a quieter, closed classroom, they did much better, even with the same group of children. So changing the environment so it is optimizing children with ADHD's function as much as possible in an environment like a classroom is important. We know that parents learning different skills may actually help in the management of ADHD. And a lot of you have participated in some of these skills, and why we recommend them is they actually do help because it gives you the tools to manage things when they occur. As well, skill development in teachers. So many more teachers know about ADHD than when I first started, which was a very long time ago. But at that time, these youngsters were just thought of as being bad kids who were troublesome. But we've learned much more and understand so much more about their talents and know that most of what happens is truly not within their control. So developing skills in teachers and parents and managing has been a critical improvement. And then finally, medication. And there's a lot of research that I'll be talking about the use of medication in ADHD. Next slide, please. So another thing that is really important about thinking about supporting children with ADHD is a concept called point of performance. And what that means is that an intervention that we hope will change a behavior has to occur when the behavior is occurring. And so when we're helping you develop parent trained education and techniques, that's helping you manage at home, but will not take over to the schoolyard. So we know the things that people do in schoolyards. So there's a program that the Hamilton Board did at one point in time called peer-mediated conflict resolution, where you train students to just patrol, and if they saw a conflict, just come up and say, is there a problem here? What's your side? And do certain little things that actually resolve a number of conflicts and reduced aggression by more than 50% in schoolyards, just by teaching peers how to manage conflicts. We know that if a child's sitting in class and doing math, and we want them to do more math or to double check, we have to think about what we do right then to help them learn how to do that better. It's not something you would teach them out in the schoolyard, for example. Extra tutoring, educational help can help them grasp concepts that they're having difficulty with. And also it often occurs in a one-to-one setting where you can concentrate better. In supporting behavior in class, another technique that can be used is daily report cards, where there's certain goals that the child works on every day, and a report card sent home every day about how they did. And then finally, medication, we think about aiming it at where problems are occurring. So it may be at home or less so, it may be in the schoolyard in school. It may be while they're participating in sports. And the use of medication can be targeted for those things, and the different preparations can be thought of depending on what environments the child in. Okay, next slide, please. A couple of important things about parenting. So it's really, really important to know that difficulty parenting does not cause ADHD. So that's not the reason why a child has ADHD. And actually, our assessment systems look into that because, of course, there are some children who are in very, very challenging environments, and that can affect their behavior. But those are things that we consider in evaluating, coming to the conclusion of that child has ADHD. But ADHD is a problem that children are born with. It's not, or it can be caused in some children if they have an injury to the parts of the brain responsible for paying attention. But the injury mechanism is much less common than just that they're born with it. We know that if parents can learn the skills that we talk about, particularly reducing what we call negative ineffective strategies, and negative strategies are telling the child they're bad, corporal punishment, talking about how when they grow up, they're just going to go to jail. That's quite negative parenting. And ineffective parenting is not following through, promising consequences and not delivering them. And we know that if we can change those types of parenting strategies, it does improve the children's skills, even extending into school. And we know that if parents participate in parenting and they medication, those are the children where it's been shown they actually improve the most. And also, if parents change those really negative strategies, those children seem, when they just looked at them functioning in the environment, that they function most like typical children. Okay, now, so that's why we emphasize developing the parenting strategies, because it does make a difference. Now, it's really important to understand that most of us give much better advice than we follow, right? So some of us, not all of us, have been parents, and we know how hard it can be, and we always don't get it right, and sometimes we make mistakes, but that's okay. It's how do you get back on the horse and move forward and you know that these are other strategies you can use instead, but we are all truly human. Okay. So next slide, please. So just to illustrate my points more, so what can teachers do? Well, seat assignments. So assigning a child with ADHD so that they're near the teacher. Arranging the room so that there's not too many distractions that would be in the sort of the gaze of the child with ADHD. You would not want to put them beside a window or maybe beside the door if the door tended to be open. The way the classroom is organized with not too many distractions. Modifying the way that we give the information to the child. Using incentives, so star stickers, or tangible rewards motivate children with ADHD and really help them more than perhaps other children. Behavior management strategies, again, looking at setting goals and motivational ideas, promoting social skills through teaching, and really, really important to have teacher-parent collaboration. Understanding that a school environment and a home environment are very, very different. And so some children with ADHD will do much better, say, at home than they might do at school. And that's not to say that anyone's doing it wrong. It's just a very, very different environment. Some families might only have one child. Some families might have 7 children. So again, the individual environment for each child does affect how they function, but it's really important that both teachers and parents understand that and work hard to collaborate and communicate because of the best situations and outcomes for kids with ADHD. Okay, next slide, please. what interventions have not been shown to help? Now, we know that therapy or psychotherapy does not help children with ADHD. Cognitive behavior therapy, where the person is taught strategies to manage, does not take ADHD away. It can help a child with ADHD as they get older learn to manage things like anger, but it may not help them pay attention better, particularly if something isn't particularly interesting. Office-based play therapy does not help ADHD. Perceptual motor sensory integration therapy, which in the past was delivered by occupational therapists, does not help ADHD. And office-based social skills training. So when kids are in a little group in an office and we try and teach them how to be social, we can teach them how to be social in the office, but that doesn't change the schoolyard. Right, so that's where we have to be thinking, as I mentioned before, about point of performance interventions. Okay, next slide, please. So I'm going to proceed to medication unless there are particular questions about what I've just discussed. Excuse me.
Great spot to pause, Bill, and check in about that. Haruka's checking in on the chat if anyone does have any questions and wants to post that, or I know if you're wondering about some of the information about the brain and all that, Dr. Mahoney said it was okay to share slides with everyone afterwards, so we will do that too.
Okay.
There doesn't seem to be any questions in the chat so far.
Okay, so I'll move forward. Okay, thank you. Okay, so let's talk about medication. So there has been a great concern about the use of medication and how it's really become much more common over the world. Its use has become much more common in treatment of children with ADHD. So and it's incredible when you think about 5 times more in Denmark, 2.5, 3 times more in different areas in North America. And we say, well, what's going on? Are people just using medication to control, difficult kids? And so what's happened is that our understanding of ADHD and the fact it continues to bother somebody has increased significantly with the research that people have done. So we know that ADHD does not go away in adolescence. I was taught that it did, actually, interestingly enough, but we know that it doesn't. We know that girls can have ADHD. It's not just boys, but it may look a little bit different. Girls may have more problems with inattention than with the classical hyperactivity. And also our understanding of attention and inattention as continuing to be a problem area, requiring treatment as kids get older, does account for why the amount of medication is more. And so that's one of the reasons. Can I have the next slide, please? The other thing is that we are diagnosing ADHD more, and so very good studies have been done through the Offord Center at McMaster about what's the frequency of ADHD. And interestingly, they did a study way back in 1980s, and they came out with about 7%. And a recent study was done by the same group where they repeated it, and it was actually closer to about 10% of children, just as a snapshot. And these are school children in Ontario, north, south, east, and west, and they looked at it across the province. And these are children who had assessments for ADHD, not just that someone said. So the prevalence of ADHD has gone up over time and is now getting closer to 10%. So we know it's a very common problem. Could I have the next slide, please? It means there's a lot of children, but in some areas still, less than 50% of children with ADHD are diagnosed, so it depends on where you live. And we've learned that many children with ADHD have stopped medication or perhaps could do better with a bit more medication. So it may not be optimally managed in everybody. We do know as well, if I have ADHD and I receive medication, most of the children are on stimulants. And I'll talk about what stimulants are in just a sec. Okay, next slide, please. So when we're stepping back and saying, well, what do we want medication to do? Well, what we want to do is to help it decrease the child's level of activity where that's a problem, to improve their ability to pay attention, and to improve their impulsivity to help them think before they do. Next slide, please. So how does it work? And if I can, next slide. Through the effect of medication on the neurotransmitters in the area of the brain that I talked about. So that's where it's working. Next slide, please. So this is a schematic slide of Ritalin or methylphenidate. And the way it works is dopamine is the neurotransmitter. That's the yellow dots. Methylphenidate is the pink little rectangles, and the red rectangles is where it's stuck into the transmitting cell, the one with the green arrow, so that the neurotransmitter wandering around between the cells doesn't get sucked up by the first cell, so there's more to transmit to the next cell, and that's why there's more activity of that blue brain cell, because there's more neurotransmitter that keeps making it fire off. And that's what Ritalin does, or methylphenidate, which is the generic name. Can I have the next slide, please?
There seemed to be a question in the chat. I'm wondering if you'd be able to answer this now. The question was, is it best to continue medication during summer when the child is off school?
Okay. Okay, I'll answer it now. And this is related to what I said before about point of performance. So it depends on what the child is doing. So some children have ADHD and it affects them. Let's say they're going to camp and they have trouble concentrating with the counselors. They get angry quickly with their peers and they're having a miserable time. Well, in that case, then we might think if medication was working that we would continue it. But if children are, say, off at a cottage where it's big, lots of room to run around, not so much structure, and there's no areas of terrible danger, then they may not need it then. So it really depends. It's the same question with respect to weekends. Okay, so some children with ADHD do best if they take it 7 days a week. There's other children who do fine if they only take it 5 days a week. Each child is an individual that way, but giving a children to drug holidays does not affect how they do in the long run. Okay. Okay. So the next question is, should my child take medication? And the word should is often used. So it's not as clear as that. So these are all judgments, but we have to, first of all, decide that the severity of the child's problem justifies the consideration. So if the child's problem is impacting their self-esteem and their mental health, might be more of a reason to use medication than if it's just, he's a bit difficult. Other interventions have not resolved the problem sufficiently. Things I mentioned in the classroom and at home, if they've resolved the problem sufficiently, so kids are doing okay, then that might not be needed. It's important to make sure that the child has been appropriately assessed because, for example, learning disabilities can look like ADHD. If the child's in a situation where he doesn't know what to do, they won't be able to pay attention to their work. So it's important that their learning functions have been assessed to some degree as well. And then finally, we have to accept, and this is particularly poignant for parents, that the acceptance of the risks, the severity of the problem allows us to accept that there are risks and potential side effects that may occur, and we accept that risk. because we have to do that on behalf of the children. Okay, the next slide, please. Okay, so what does medication do? Now, each point that I make with this is that these are things that have been done in studies that are what we call double-blind, placebo-controlled. So these are situations where the child is either given medication or a sugar pill, and nobody knows what the child received. Not the doctor, not the observer, not the parent, and not the child. And then we compare the child's functioning with the drug and with the placebo to see are there differences. And when we do that, we know that medication does decrease impulsivity. It improves compliance. So if you ask Johnny to do something, Johnny actually does it. It improves following the rules, general rules that are present in an environment. It improves the percentage of seat work completed and its accuracy. It improves the way teachers rate behavior. In some children, improves their handwriting. So you wonder why all doctors aren't on it, perhaps. And then it can definitely decrease fidgetiness, or the children who are bopping around all the time. Next slide, please. It decreases negative social behavior. So doing things that seem to be a bit mean or causing trouble, that doesn't happen as often. It can improve performance sitting in a laboratory. It reduces vocalizations and noise. So a lot of kids with ADHD whistle while they work, and that's okay if they're by themselves, but it's not okay if you're sitting in a classroom or it's a test time. It can improve central auditory processing testing. That's something that people used to do a lot of in children who are having difficulties. Another thing it does, it decreases controlling behavior of mothers and teachers. So controlling behavior are little things that we use to keep a child on task. Pay attention there. Get back to work. You're drifting off. And we do this a lot if we see kids not accomplishing or doing their work. And if a child takes medication, we don't do that as much, even though we don't know the child had medication. So it changes the quality of the way a child behaves. That may be subtle, but leads to the next point is they get a lot more positive attention. So you're doing a good job. Hey, you did that well. Gee, you got a really good mark on that. Occurs more often. Now I say mothers, and why do I say mothers? It's not misogynist. The reason why is when these experiments were done, who takes their children or was taking children to the doctors back then? In the old days, it was always the mother. So they were available to do these experiments in the old days. I'm part of the old days. Anyway, so the other thing is the intensity of interactions by teachers, sort of that intensity of the voice like that decreases when children take medication, and then it reduces off-task behavior in class. Okay, next slide, please. So another thing that's really, really important is that it does not improve a child's core ability to read or do or understand math. When people have studied children who have ADHD, particularly the hyperactive impulsive, or what they call combined, and they look at how well they did reading and math. If they did not also have a learning disability, they actually did reading and math as well or better than their peers on average. It's just they don't perform as well. Children with only inattentive ADHD don't do as well in general on some of the reading and other kinds of problem-solving tasks. But medication did not improve those learning abilities. It improved them doing more works at one time and concentrating, but does not necessarily improve their understanding or reading comprehension. Another important thing, and I'll talk about this a little bit more, because many drug companies have argued, well, you need to get the children on medication because that way it'll change how they are when they grow up. And actually, there's fairly good evidence that it doesn't do that. So it doesn't. If you don't use medication, it does not mean they will have a negative outcome such as delinquency when they grow up. But if you do use medication, it doesn't mean it won't happen. Can I have the next slide, please? There's certain situations where we feel it's important to use caution with ADHD. So young children under the age of 6, children who are severely anxious, children with tic problems, which are little motor movements like blinking or shaking your head, or if they have Tourette's syndrome or a family history of those, we're concerned that sometimes medication can make those symptoms a little bit worse. There's some controversy about that. If the child has not been appropriately assessed. So for example, I've seen situations where children with ADHD and learning disabilities improved in their behavior, but people did not attend to their learning problems, so that they basically made no progress academically over the year that they were on medication because people weren't dealing with. It should not be the first thing we do, and if the side effects are incapacitating, then we have to respect that, because we don't want children to feel miserable. If they've had a previous history of adverse reaction, or if we do feel they're actually depressed, sometimes the medication can aggravate that. Okay, next slide, please. So let me talk about the specific medications. There's what we call the stimulants, and that's where I'll be talking about firstly, and they're the most common ones used. There are 2 types of stimulants. There's methylphenidate, which is commonly known as Ritalin, or these other considered bifenton. And then there's the amphetamines, which are dexedrine, Adderall, and Vyvanse. I'll talk a little bit more about them in a sec. Next slide, please. Oh, sorry, next dot. Yeah. So there are also what we call the non-stimulants. There's atomoxetine, also known as Strattera. There's clonidine, that's also known as Catapres, and guanfacine XR, which is known as individualized. Clonidine and guanfacine were both developed as blood pressure medications, but we have found that they can help some children who have ADHD. Next slide, please. Are we stuck? There we are. Thank you. So another thing is that what is the probability if we give a child medication that's actually going to help? And what we've learned is it depends on the medication. So we know that the stimulants work about 80% of the time in helping children with ADHD. Whereas atomoxetine, also known as Strattera, it helps about 65% of the time. There's some antidepressants that people have used, and then there's clonidine and guanfacine, which really only help about 50% of the time. And that's why we usually pick a stimulant first, because it has a pretty good chance that it's going to work. Believe it or not, when it comes to treating disorders that are, in quotation marks, mental health disorders, there's no other medication that people use that will work as frequently and often as quickly as the medications for ADHD, which is quite striking. Okay, next slide, please. So now, which one do we pick? We know that 38% of children respond to both, some to one, some not to the other. We know that up to 80% respond to methylphenidate, and there may be slightly fewer side effects with methylphenidate when compared to the amphetamines. That's often why people start with methylphenidate. Okay, next slide, please. So methylphenidate, the most common one over time has been Ritalin. We give the dose based on weight. So that's 0.3 milligrams per kilogram of weight per dose, with each dose lasting about 4 hours. And so in the old days, children with who were taking Ritalin often had to take it 2 or 3 times a day because it would only last 4 hours. And this often led to them needing to have the medication in school. And in some schools, it was a bit negative, because at lunchtime there'd be this long lineup outside the principal's office for kids waiting for the medication, which can be somewhat stigmatizing. This led to the development of more long-acting forms of medication that come in different sizes. And one is bifenton, which is lasts about 8 hours. And the advantage of bifenton is that it can be opened and sprinkled on applesauce. Concerta lasts about 10 to 12 hours. It comes in fewer sizes, and it's a big pill. So if children have trouble swallowing pills, often they can't take Concerta. There's a new one that's come on the market called Foquest, and it as well can be sprinkled, and it lasts up to 16 hours. And there's some that you can measure in the bloodstream, a significant portion of it, the next morning. So that may be to a child's advantage, but maybe to their disadvantage, because one of the side effects, and I'll mention a bit more, is difficulty falling asleep. And that level of medication would interfere with falling asleep, and also they would have poor appetite for things like dinner, which is one of the other side effects. Next slide, please. So dextroamphetamine or dexedrine, it has long-acting forms available as well, and the dose is half the dose of methylphenidate or Ritalin, as doctors are trying to think about what's the best dose. But it has a few more side effects and more abuse potential than methylphenidate does. But it is important to acknowledge that there is a market for both of these in the black market on the street. So there is a market for both of these medications. An intermediate acting about 8 hours is Adderall XR. And then finally, there's Vyvanse, which can be, the capsule can be opened and it can be dissolved in liquid. And its effect lasts about 12. See, there's a lot of different choices and how the medication can be aimed at what I called the point of performance. Where the difficulties are affecting the child. Sometimes it's mostly during the day, other children, it's throughout the day. And we can target the way we give medication depending what the individual child's needs are. Okay, next slide, please. Sorry, I just done this. Can we go to the next one? Sorry. Okay, so when children are taking medication, how do we monitor? So first of all, it can be done by the child's primary care physician, because what we need to do is find out how it's working, what the side effects are like, and continue to monitor their height, weight, and blood pressure. It is not necessary to do any blood tests for methylphenidate or dextroamphetamine stimulants. There is not a need for blood tests, which children are quite relieved by. It allows our ability to reinforce other treatments like the parenting or giving advice about managing some school issues that occur. So it's good to have contact to be able to discuss that. And the other thing is we need to allow increasing input from the child, because children notice the effects of the medication, both the positive and the negatives. And a number of the adolescents will say that it makes them feel funny or act different. And some of them don't like that. And if it affects them, like some adolescents, what makes them appealing is just the way some are really happy-go-lucky and people think that's really cool. And then if they take medication and they're quiet and they're different, they don't get the same positive attention from that behavior. And if they notice that, they say, well, wait a minute, I don't know if I really want this stuff. So we have to work with them as they get older, and they have to participate more in the management. Because you can't use, in a great big 14-year-old, you can't use a funnel and a plunger to put it down their throat. It's just not appropriate. Okay, next slide, please. So what should you pick, right? It depends on the target. So we know if a child takes a long-acting form or takes it 3 times a day, their behavior will improve more at home after school than if they only take it twice a day or an intermediate acting form. However, there is more appetite suppression and less sleep if you take it 3 times a day, because the effect's there for longer. there is some evidence that if I take it 3 times a day, 7 days a week, 365 days a year, it may affect the child's weight maybe up to 2 centimeters. And we don't know if they recover from that if you stop the medication. And that does not appear to happen if the child has periodic times off the medication, like the summer, as was asked in the question. So finding the right dose is important because there's not one dose fits all. Another way of measuring that, if there's any questions, can be using some of the rating scales, because it makes it a little bit more objective and allows us to get as well the teacher's input, because the teacher is observing the child throughout the day, which is often the time that the medication is targeted at. Okay, next slide, please. Now, one new problem, if you have a child who's been on Concerta, is the policy in Ontario, if you go to renew a medication, that the pharmacist chooses out of the drug company form because it's more economical. However, the generic Concerta is called Methylphenidate LA, and it's very different in the way it's released. It's not released in a gradual way. It seems to be released in 2 big pulses, and it's more like taking it twice a day at higher doses than a more gradual overall 3 times a day. So that's important if your child is taking Concerta, that you're careful of, and the doctor has to write no substitutions to ensure the child is taking the regular Concerta. And the publicly funded drug program does pay for regular Concerta now. At one time it didn't. So that's just important in that very, very specific instance of generic Concerta. Next slide, please. Sutera is another medication we might use in 3 situations. If a child has really bad tic problems or motor tics, if a child has really bad anxiety, or if the other ones haven't worked, sometimes atomoxetine will. However, it takes much longer to know if it's helpful, at least 3 weeks, where it's with the stimulants, you know if they work often within 2 or 3. You may not know its full effects for 12 weeks. And the side effect if you give too much at once is fatigue. The children feel fatigued. And if you go past the maximum dose, so 1.2 milligrams per kilogram of weight is the target dose where it seems to have the best effect, but it's not like more will make it, to use poor English, more better. So it has to be worked with to find the right dose over time, and it's harder to work with. That's important. Next slide, please. Okay. Guanfacine XR is also called Intenov. It's relatively new in Canada, only comes in 4 sizes. It's important to monitor the blood pressure because it might get too low. The other problem with this is that it is quite expensive. 1 pill costs about $3, and it is only covered by the drug plan if the child fulfills certain criteria, including demonstrating that the stimulants didn't work, is one of the things that the government insists on in order to try this, or they have not worked well enough. So you can't just go right to it. But it is relatively new, but may not have quite as many side effects. Next slide, please. So to just sum up, with medication, it's rarely the only intervention or the first intervention. Another thing is the high placebo rate of response. So what that means is that if I do an experiment with things like Ritalin or methylphenidate, and I give one child the sugar pill and the other group the methylphenidate, but I only study 30% of the kids getting placebo seem to get better to the people who are observing them. 30%. That's almost a third. But significantly more get better if you give the regular drug. That's why it's able to be recommended. But 30% is quite high. And so we have to be careful about that. I facetiously say that, if I was greedy, I could market sort of Bill's vitamins for ADHD, and I'd be right 30% of the time. And that would probably help me look really good for a while, but it would only be the placebo effect. Prescriptions need to be individualized. What's right for one child is not necessarily right for the other. And we have to make sure that we know what we're trying to do. So what are we helping to do? And can we measure whether or not that is actually working at home or at school, depending on what the targeted behaviors are. We need to be thinking about this all the time when we're prescribing medication. Next slide, please.
There's just a couple of questions in the chat now, if you'd like to take a look at them.
Let me do this and then I'll come to that, okay?
Yep, that sounds great.
Okay, so at one time people believed that it was a diagnostic test. So if they gave medication and it got better, it meant the child really did have ADHD. That's not accurate. There was a study that was done in Washington and the National Institutes of Health. This is in the old days where they could do this kind of study. They took children of the professors there, and they did a double-blind study of dexedrine in that case, and they did show their attention got better when they gave them dexedrine, but they refused to take it because of the side effects. So it's not a diagnostic test and may improve anyone's attention. The medication will cure the problem. It does not take the problem away. It just helps manage it when the child is taking the medication. There's a belief that a child would learn if only they would pay attention. And it doesn't work that way. But they don't acquire skills such as reading or math better with the use of medication or not. Some people worry that there's a high risk of addiction, and there's clear evidence that that's not so. And other people are concerned that there's high risk with the use of medication. And actually, and I'll talk about this, there is a degree of reassurance about what we learned about side effects. So I'll take the questions now.
Yes, they are in the chat. I'm not sure if you're able to see them.
I just pull up the chat. My apologies. So
no worries.
What about Intanove and Concerta combined? Yes. Usually we want to try one, like Concerta, or the next question is bifenton. And do we get a good enough effect without too many side effects? If there's some effect, but we would like to make it, again, to use my bad English, more better, then we will add Intanove, and it's been demonstrated there can be additional improvements in attention with the addition of Intanove. What is better to treat extreme mood fluctuation? Stimulants often are not the best thing for that. There's other medications we think, depending on what we think the mechanism is for mood fluctuation. So that's a more complicated question, but we would usually not treat stimulants with that. Is nail biting or nail picking a side effect of medication? Yes, it can be. Yes, that's no, and skin picking as well can occur more as a side effect of medication. Okay. So go to the next slide. Now, sorry, I just taking off the chat from the screen. So now you may have been to the doctor and they have a blue book. Now there's less there now because we all use the internet, but so now there's an internet blue book. But you may remember there was a blue book that was in each doctor's office, and it was what they call the Compendium of Pharmaceuticals, Substances, or something like that. And we would look up the doses and things like that in that blue book. And in that blue book, they always list the potential side effects of the medication. So this is taken from that blue book and say, what are the side effects of methylphenidate? And they say nervousness, difficulties falling asleep, hypersensitivity, poor appetite, feeling sick to the stomach, dizziness, feeling your heartbeat, headache, difficulties with motor movements, increases in blood pressure and pulse, cardiac arrhythmias, abdominal pain, weight loss, toxic psychosis, and visual disturbances. You say, holy smokes, I would never give my youngster something that would do that. That's really, really concerning. So if I could have the next slide, please. So has anyone ever taken aspirin? Okay, so these are the side effects of aspirin. Rise syndrome, which is a fatal liver disease, nausea, vomiting, bleeding, heartburn, ringing in the ears, even hearing loss, dizziness, sensitivity, anaphylaxis, and very severe allergic reactions, liver damage, mental confusing, being sleepy, sweating, thirst, and bleeding are all side effects of aspirin, and wouldn't be that dissimilar to Advil with not so much bleeding. So all medications have side effects. They're in the use of the stimulants. The more severe ones are very, 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 very rare, but we can never say never. Going back to the point I made, in using medication, we have to accept, and this is what's so hard for parents, this degree of risk that we could potentially expose a child to, but it's never say never, but it's very rare. You know, it's the same issue that people are going through with these potential side effects from the vaccine, right? It's very, very rare. Some of them are 1 in a million, but it happens, and so we have to be thoughtful about that as we're trying to decide whether or not to use medication. Okay, next slide, please. So when someone says, well, how often do kids have side effects? A fellow by the name of Russell Barkley did a placebo-controlled study where some kids got the medication and some kids got placebo, and they looked at side effects. And so what they found is with placebo, which is the second line, 40% of them, the parents felt they had more insomnia, 49% they are more prone to crying, 72% felt to be more irritable, 58% more anxious. So even on placebo, the parents perceived them as having a lot of side effects. But when they averaged it out, difficulties falling asleep, poor appetite, headaches, and tummy aches were increased in the methylphenidate or Ritalin group compared to the placebo group. So that's why we say they're the more common side effects. But less than 50% of kids had an increase of side effects because of medication, and only 3% had side effects severe enough to stop the medication, and those side effects were gone within 24 hours. Now, this was a small group. It was only 83, but it allowed us to come to those conclusions, but it wasn't looking for the more severe medical side effects that I mentioned before, which are only discovered by surveilling large populations who take the medication. Okay, next slide, please. So some children can have withdrawn behavior. Some can be sad and appear to cry and be more sad. And those side effects may increase with time. They may not be immediate. It does affect weight gain, but given with drug holidays, that may not have an effect on growth. But some effect on growth with TID means 3 times a day doses. We're giving it 3 times a day. And a study done in preschoolers showed that they may be more sensitive to growth effects of the stimulant medications. Okay, next slide, please. Atomoxetine or Strattera, the side effects seem to be more the feeling sleepy and decreased appetite seem to be the ones that were more often compared to placebo. The left is placebo, the right is the atomoxetine, and it does increase with dose. As well, there is a small risk of liver problems with atomoxetine that is not present with the stimulants that parents need to be informed about if they were going to decide to use atomoxetine. Okay, next slide, please. Finally, this is less controversial than it used to be. This was very concerning back in the early 2000s, where there were reports of sudden death in people taking methylphenidate and dexedrine. When people analyze this information, the background was that we know, unfortunately, that there is 1.2 sudden deaths in every 100,000 people per year of the same age, and these people are not taking medication. So it's an event that happens, unfortunately, and very sadly, and it's quite unclear whether it happens more often in people taking medication than people don't when they look at comparing those two groups. So that seems to be very rare, and we often ask about a family history of heart problems or sudden cardiac events in a family, and might do an electrocardiogram if there's a clear family history of that. Okay, next slide, please. I want to talk about preschool studies. There's a study that was done a little while ago, but it was for children who were 6 and under. Next slide, please. And interestingly, from that study, the first intervention they got to enter the study is they got parent training, and in about 15% of them, the problem went away with parent training and never came back. They began on twice a day dosing, a very small dose, and a small percentage on medication, but 13% of people on placebo got to the point where the behavior was felt to demonstrate they didn't have the problem anymore taking medication, but it did not work as well in older children, particularly for parents. And there were more side effects, which led to more frequently discontinuing the medication in preschoolers. And there did appear to be significant effects on height, and we don't know whether or not those effects went away. So remember I mentioned in preschoolers, you've really got to use caution. And so it really requires really good thought that the problem is quite significant to justify thinking about using stimulants in preschoolers. So we do that in exceptional circumstances, but certainly it has to be a very thoughtful approach. Next slide, please. Okay, so I'm going to talk and close with talking about a trial that was done in the early 2000s. And it illustrates some of the points that I've made. And this was a study that was done where they had a group of kids with ADHD. One group got only medication. One group got only behavior treatment. Another group got combined treatment, so both behavior and medication. And the medication meant going to the doctor and seeing the doctor and talking about the dose once a month. Okay, so they went to the doctor once a month. And then the final group was just said, you go back to your pediatrician or family doctor in the community and let them take care of the problem. So they had 4 groups, equal numbers, each one having the individual treatment approach. Okay, and so next slide, please. And so when they looked at these groups 3 years after being in the project, they say, well, what happened? How did one group do better? Did the kids who got the best research study dose do better? The people got the behavior treatment that was really expert, and the behavior treatment was tutoring, it was an educational assistant, it was parent training, were all parts of the behavior component. So these kids got really good help. But then we looked at all of the groups after 3 years, they all looked the same. That was very interesting. In the short term, it seemed the medication worked a bit better, but it all washed out after 3 years. Next slide, please. If you asked, okay, they now had a group of typical children to compare the kids with ADHD to, and what they found was that negative problems occur in the typical children as well as the ADHD children, but they happen more commonly in children with ADHD. So around age 11 to 13, proportions of them had delinquent behavior, substance use, more than half had some evidence of delinquent, maybe taking from a store, they would call that, or mild delinquency. Some of them were already engaging in alcohol and cigarettes, and a little bit of use of marijuana. Can I have the next slide, please? So all these problems happen in typical children, and children with ADHD are more at risk for these problems. But we believe that taking some of the approaches that we have will increase the probability they'll have a good outcome, but it may not happen despite our best efforts. So we know that children with ADHD, just some interesting information, they respond better to the frequency of a consequence, not its size. So inflating a consequence, for example, going from go to your room for 5 minutes to grounded for 3 weeks, that will not change their behavior. But having the same consequence applied each time, for once it's, you know what works, that actually is a better approach. We know that children with ADHD have a high risk of substance use, but behavior interventions, the parenting that I was mentioning, that might be protective in the long run as opposed to using medication. As you follow kids who are older, if they're still on medication, they're more likely to be delinquent, but that suggests that their problem is more severe. But what treatment they got did not influence delinquency, and the more severe it is, the harder it is to treat. The other thing is, if we run into situations where the child has severe ADHD and their caregiver is mildly depressed and they have cognitive difficulties, those are children who don't do as well as others. So we need to think about other ways of intervening to try and help them to do better. And one of the interventions may be indirect, such as treating and helping a caregiver or happens to be depressed, can sometimes be a powerful intervention in helping the child with ADHD. The other thing is, if a child has both ADHD and anxiety, is that those are a group of children who really seem to need the behavioral supports as well as the medication. Next slide, please. So when they looked at these kids about 8 years later, they concluded that yes, it helps, but it doesn't make it go away in a wide range of functioning of kids with ADHD. And there's a practical need to try and come up with new ideas to help, particularly older kids with ADHD, to try and shift the treatments, rather than just looking at ADHD symptoms, to how is the child doing and functioning in a general kind of way. Okay, next slide. Okay, so alternative therapies, diet. Can I have the next slide, please? Okay. So in diet, there is some evidence that omega-3 fatty acids can improve mildly functioning kids with ADHD. Restricting additives and food dyes, particularly in young children, can improve some children who have particularly the hyperactive children with ADHD. There is recent evidence and ongoing research in biofeedback, which is where the child learns to control their brain waves while looking at their EEG, but it's unclear whether it's effective, and it's very, very expensive. The other concern is does it generalize? So if the child learns to treat their brain waves in the lab, does that help them in the schoolyard? And to some degree, that remains unclear. Okay, the next slide, please. Okay, so we go back one. Go back one. Go back. Okay. Thank you.
Sorry, I'm just trying to figure out how to go backwards.
That's okay. It worked very well. So that's the content. So certainly do questions, please.
Yeah, we'll definitely pause for a moment while people are thinking about any questions they have. That was a lot of really interesting information, and we don't usually hear that shared so openly and so realistically, I think. And I'm sure lots of people are thinking about things depending on, how things are with your child and how old they are. I see something flashing. Does that mean there's maybe some questions now?
Yes, there's one question. The question is, what is the best way to get a proper diagnosis?
Okay, so most pediatricians now, as part of their training, receive education about the assessment and treatment of ADHD. One of the important aspects is how do we measure symptoms, and that's with the use of certain rating scales. And people think that, well, rating scales are subjective, but it's actually more objective than just getting general information and impressions. So we ask the parents and teachers to rate behavior, and looking at the number of symptoms and their severity is what leads to the conclusion that this is the phenomenon we call ADHD. Now, some family doctors, but maybe not as many, are educated in how to do that. But I certainly recommend that has to be done before we conclude that the child has ADHD, because the symptom count is enough. So an example, you're supposed to have 6, 7, 9 in one domain to say you have ADHD. If you only allow 5, your frequency of diagnosis doubles. So it's important that people are careful making sure the child does meet the criteria for ADHD. Then psychiatrists and developmental pediatricians also are trained in that. But if you only saw people of that level, the waiting list would be years and years long. So that's why the first step is your family doctor, and then perhaps a community pediatrician. Sorry, the one question was, did the last 2 slides get skipped intentionally? They were illustrations of the ineffective parenting that were there, if that was a question. So I wanted that to remind myself. So that was the reason why I skipped through it. I wasn't trying to say, and that would be good, that would be shared with you afterwards. There's a question, is there a link between ADHD and executive function difficulties? And the answer is some. So for example, one of the executive functions is called planning and organization, right? And we know that they jump into things before they plan. And so you can see how, yes, people with ADHD very often don't have that executive function. Another is monitoring, self-monitoring about how I'm doing, and using feedback to adjust my behavior as an executive function. And again, people with ADHD have difficulty with that. Another executive function is what they call working memory. And what working memory is keeping things in your head and manipulating it, such as doing a math problem or a math word problem. And in that, many people with ADHD don't have any problems with it. So it's not like they have a generalized executive function, but it's more specific executive functions are also components of ADHD. So that's the relationship. Okay, and now let me go down. Okay, so a psychoeducational assessment. Sorry, I'm just closing my blinds here because it's dark outside. A psychoeducational assessment is not necessary for the diagnosis of ADHD. The diagnosis of ADHD by does the child meet the criteria, usually through age of onset, looking at other things that might explain the behavior, Is there a learning disability there, which can be done just by saying how well does a child read, write, and do math, and then look at the number of criteria that are present, and that's enough to make the diagnosis of ADHD. However, in complex situations, for example, does the child also have a learning disability, or a language disorder, or other things that might explain the behavior or affect other areas of function? That's when a psychoeducational assessment can be helpful, but it's not necessary at all for the diagnosis of ADHD. So, so the question was, and then so I can't say specifically, these are all choices that could be reasonable is what I could say, because the parent says they're worried about weight loss and would love a break for the summer, but at the same time to find what works. So there's no wrong answer to that. It's doing what works, and so that's certainly with your physician something to discuss. You cannot stop Intenov suddenly, however, because there's a risk of the blood pressure going up suddenly if you stop Intenov too quickly. So someone said that this is, I didn't discuss many of the alternative medications. So I did discuss the parenting and the classroom strategies and techniques. If people want more information about those, there's certainly resources and courses for that. So there's our parent education guide. I don't know if you see it, it's put out by the Ron Joyce, that has a number of courses and programs that you can take that build the skills that I was talking about to optimize the child's behavioral functioning, particularly at home. And the idea is for teachers now receive a lot of education about this. And interestingly, schools now have people called board certified behavioral analysts that have been placed in the board. Their primary purpose was to help children with autism, but they are truly experts in helping manage difficult behavior and have been a tremendous resource to many teachers and other people in the board about how to help kids who have ADHD. Principles are the same, even though it's a different condition. So there are all these resources that weren't there before that are there to help children and their families, and how to help them function better. I can't go into all the details of the parenting ideas, just because that's a whole course. So I couldn't do that. So next question is, for teenagers getting close to adulthood, does medication change need to be considered? And so certainly the teenager has to participate in that. We find that you may not need as much medication based on weight as you do in younger children. So they may not need as much. And also they have input into whether they need medication or not. So some adults with ADHD function very well because they're into them an interesting job, and their positive characteristics really help them be successful there. And if that's the case, they may not need medication. However, if they're also in a situation where their ADHD interferes significantly with their relationships, then they have to think about it. So it all depends on their own individual circumstances and their participation in that. The other thing is that for young teenagers to older teenagers, many of them don't want other people to know that they take medication because it's got a really bad reputation. Some of them might want to boast about it, but it's, that privacy has to be respected. So the form of medication may have to change to respect the pharmacy. So next question, to respect their privacy. How do you know it's time to try medication? as I mentioned before, it's a judgment where what other things can be done have been tried, and we still need to do more to help the child be more successful in their environment. So it's looking at how they're doing in their social situations, academic and home situations. And if the ADHD symptoms are really interfering with their function, which leads to them feeling badly and other people feeling badly for them, then that might be the time. Where if it's, well, you know, they're doing okay, their marks are pretty good, and they seem to do okay when they're out playing with their friends, they don't get in more arguments than other children do, then that might not be a time to use medication. So how do we address anger fluctuations? So part of this is based both on age and strategies. So so for example, we know that there's different ways of dealing with a behavior. So you see a child doing something you don't want them to do, you say, no, don't do that, stop that, right? That would be what we would do. But another thing we can choose to do is say, why don't we go and do this instead? Right? That's another strategy to prevent an anger fluctuation. It can work just as well in stopping the behavior, right? So that's where using the ideas and strategies that we talk about can actually address that. Now, some children, it's more significant than that, and some children, it can be very severe where they're having anger outbursts, multiple times a day, and when it's quite significant and there's a lot of anger and arguing and deliberate anger, we call that an oppositional defiant disorder. We know that that actually does respond and get improved with the parenting education. And in very severe situations, there's some other types of medication I did not talk about that you can deal with a physician that can directly address that, but they have more severe side effects. But so those are different levels of escalation. Another thing is really differentiating between anger and temper and meltdowns. So meltdowns are where children totally lose control of their behavior. And we know that when kids are overwhelmed, that can happen. It often happens also when kids are anxious. Excuse me. And we know that if that's the mechanism, the approach to it is preventing it. It's more effective than trying to deal with it. So how do you talk to this? So again, it's a sensitive issue, and it's at the time when the child is asking questions like, why do I get into trouble? Why does this happen to me? Why do I have to take this medication? And that's where it's time to sit down and talk about how they are built a little bit differently. They have lots of talent, but this difficulty does get them into trouble. And we call that ADHD, or attention deficit hyperactivity disorder. ADHD is easier because the other is such a mouthful, isn't it, for kids? But that would be but my thought is at the time that you think they're ready. Now, it changes with time. So for example, it's around age 9 that children are socially don't want to stand out. And it was often between age 9 and 11 that we had to stop giving medication at school because no kid wanted to stand out in front of the principal's office to get their medication because it made them look really odd or indifferent. So that taught us to appreciate those sensitivities, and that we need to talk to kids about why we're doing that. And certainly with older kids, adolescents, we have to talk to them to get their assent and consent to what we're doing and the reason why, because it's important that they ultimately are going to have to manage what their issues are. So it's a gradual process, and it's being very sensitive to when the children are asking questions or noticing that they're different. Okay. Any other questions? Okay, thank you.
Okay, thanks, Phil. I'm like, there's 2 mute buttons. I'm like, how many did I push? I just wanted to comment on a few of the questions. It seemed like it would be helpful to get connected to some of the other sessions or recordings or other resources that are out there around the the different parenting strategies and different approaches to problem solving and things like that. And so on the Your Space website, there are quite a few that would be relevant to that, and of course the Community Education Service at Ron Joyce has some closed groups. We just finished a 3-session series on parenting your child or youth with ADHD, and those ones aren't recorded. However, they're offered on a regular basis, and we'll put you in touch with the Community Education Service calendar so that you can look ahead to that. I know some of you might have signed up and are here tonight because you were participants in one of those series. So there is quite a few things out there, and we'll make sure that we put those on the resource page for today's session so that you can connect to those as well. And I did jump back to this slide because way back when I was trying to go backwards and could only go forwards, I I did that, so I still don't know how to go backwards. And just to follow up, the other 2 slides that are in here, Dr. Bill, if you want to speak to them, you're certainly more than welcome to. And I know you've already talked about it a bit. And I just wasn't sure because I am a parent with kids with ADHD, and I know that I've worked hard to change how I think about my child, and I know some of the wording here I know is related to, let me see, oh, now it won't go forward in slides either. Oh, there we go. That now it, some of the research things and what they talk about and how they identify and label things might be different now or different in different people's contexts. So Dr. Bill, feel free to go ahead and touch on this because I know this was part of it.
So these are things that parents have done for years, and sometimes it's okay, but we know particularly with kids with ADHD, some of these things either don't work or can teach the child that there's other strategies. Sometimes it's losing your temper. Sometimes it's talking yourself out of the behavior. That if there's no consequences, if you don't, find out how the child's doing when they go home from school, that your punishment depends on your mood, right? And now some of this is just normal life, and appreciate that. The numbers are the ones that are really ones to try and not do. That was why the numbers were put in there. And the one thing is it's much less common now, but there certainly was a time not all that long ago where there was a large group of people who still believed in spare the rod and spoil the child. There was a time when I was in school where there was a lot of things that happened to kids in school, like getting the strap. And what we've learned is that is not effective in children in general, particularly is not effective in children with ADHD. And we know that corporal punishment after the age of 8 makes aggression significantly worse. So it teaches the child to be aggressive, and we know that there's very, very negative consequences from that. So that's why it's mentioned and emphasized that there are definitely other strategies that work better. So those are the ineffective ones, and the previous one, I believe, is the harsh negative ones. So avoiding arguments is important. Depriving privileges, just in general, you've done this so you don't get dessert. just in general, but not in a methodical way. Yelling really doesn't work very well, but it's really hard not to yell. You know, that's hard for all of us. And I can confess that I sometimes yell at my kids. Yep. And I know I'm not supposed to, but anyway, it's hard. Arguing, getting mad, being too directive rather than giving choices. So we know that giving choices is a strategy. You know, an absolute forbidding, like you will never go to Johnny's house again. Nagging doesn't work, and things that make the child feel bad. You know, how can you be so dumb? You know, those kinds of things. The other thing is saying that you're going to grow up and end up in jail. Those kinds of statements really don't work, and not doing those kinds of statements actually helps the child do better.
Thank you, Dr. Bill. I think that was a great way to frame those. I know that the one of the things that Sue and Michelle talked about in the Parenting Your Child or Youth with ADHD course is, you know, kids don't choose to have ADHD, and the brain is what the brain is, and a lot of times, and if we can do things that kind of help their brain when their brain's maybe not helping them out, then that gives everyone a chance to feel better and do better. And just the same as you know, we wouldn't yell at our 6-year-old because they can't reach the highest shelf, because they're just not there yet. They haven't grown, and it's not in their control to do that. So sometimes it is that different way of looking at things, that your child doesn't choose to have these challenges, but they are there.
Thank you.
So I'll check again if there's any comments or questions in the chat. And I know we've definitely filled the 90 minutes up, and especially on the top of the late start because of the tech issues. So we really appreciate everyone sticking it out, and especially you, Dr. Bill, for working with us and being here tonight and being so flexible and generous with your time. So we're all good. Nothing in the chat now. Okay. Haruka, if you were sharing anything, your mic's off.
I can do the quick wrap up if that's helpful. Thank you everyone for joining our session tonight. The resource page will be shared through email the same way that you received the link, and it will be by email in the next few days or so. And as Louise said, feel free to take a look at the other sessions that's been offered. They are under resources on your Space website. Great, thank you so much. And thank you for staying an extra 20 minutes or so tonight. And thank you, Dr. Bill.
Okay. Good night.
Thanks, everyone.
Have a good night, everyone.
Bye-bye.